Okay, well, let me introduce Dr. Zaleski. Chris Zaleski comes to us from Omaha, and Dr. Zaleski has also presented at least 2 other of our conventions. And I will tell you that he is a guy who technicians are really close to his heart. Not only does he help me on a regular basis with what we call skill assessments at the university, but he also helped organize a scholarship for pharmacy technicians. It's a $500 scholarship that's awarded every month. So if you are interested in, and this is for an individual who completes a program at the university, we do have a national program. So even if you're not in Nebraska, if you're interested in, and this is for someone who's not certified, you're eligible for a scholarship, and he helped organize that. So I'll let Chris tell you more about his background, but please help me in welcoming him.
Thank you, Judy. So like Judy said, my name is Chris Zaleski. I'm a pharmacist at Nebraska Medicine in Omaha. I currently oversee our hub pharmacy, which is our central fill pharmacy. And so we're overseeing 3 different pharmacies worth of work and a team of close to 50 to 60 technicians. So lots of technicians on my team that I work alongside, and it's a joy to work with all of them. I mean, I would be lost without them for sure. So for this talk today, kind of keeping in line with the theme of this morning, we'll talk through the science of addiction and giving a review of the pathophysiology, some of the pharmacology of the medications. So kind of taking more of a dive into some of the meds used to treat alcohol use disorder, opioid use disorder, and we'll also touch on some medications for smoking cessation. And then we'll go through some resources and different things that we can do within the pharmacy to help these patients. So objectives, we're going to take a look at the pathophysiology involved with substance use disorder, again, look at some of those medications, and then look at some of the resources, and then what can we do in the pharmacy specific to what can the technicians do. And so I start with this definition here that I found. So addiction is a treatable chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and an individual's life experience. And so the reason I like this definition here, a few reasons. One, it describes it as a medical disease, which we've already kind of seen a little bit of that with the first 2 topics today, but knowing that this is a medical disease, it's not, the patient is not the problem, it's the patient has a disease, I think is important to understand here. And then it's also based on an individual's life experiences, so it's personable. It's all these things that happen to a patient throughout their life that can lead to addiction and substance use. So giving a brief background, I know we've already touched on this a bit, but the DSM-5 categorizes substance use disorder as a disorder characterized by patterns of symptoms caused by using a substance that one continues to take despite its negative effects. So we understand that this is going to be harmful, yet we still continue to use it. And they break it down into 4 different categories here. So we've got impaired control over substance abuse. So that's when we're consuming larger amounts for a longer amount of time. We have the persistent desire to cut down or regulate use. These patients want to stop using these substances. They continue to try and regulate how much they're using. They spend a lot of time obtaining and using and then recovering from the substance. And then they experience these cravings, which we'll talk a bit more about in a bit. Of course, we've got our social impairment. So it impairs the ability to complete tasks at work, school, or home. And then continued use despite these social or interpersonal problems, as well as a decrease in just social activities, occupational activities, just things that we would normally do on a day-to-day basis. And then that transitions over to risky use of these medications, so using them in an unsafe environment. And then using it despite knowing that it may exacerbate or prolong a specific problem that the patient may have. And then from a pharmacologic standpoint, we have tolerance and withdrawal. which we'll see here in some subsequent slides, but tolerance, using higher doses to achieve the same effect, as well as withdrawal with those signs and symptoms associated with decreased levels of that substance. So, we'll take a look here. Question, what's the pathophysiology involved with substance use disorder? I think Dr. Sullivan gave us a good intro into the reward pathway here. So I have a brief little clip here.
Addiction is defined as not having control over doing, taking, using something to the point where it could be harmful to you. Previous to understanding the science, it was thought that addiction resulted from a lack of willpower and was a moral failing. But we now know that addiction is a physiological disease. It changes the brain structure in ways that can alter the way it works and process information. To understand how that happens, we start by thinking about reward and the brain's natural reward system. The reward pathway's primary function is to reinforce sets of behaviors. Evolutionarily, it began as a way to indicate to us that actions that help us survive are good and we should keep doing them. This is mediated through a chemical called dopamine. Following an appropriate behavior, the reward pathway releases a small burst of dopamine. That burst of dopamine is a satisfying jolt, encouraging you to repeat the same action in the future. Dopamine will in turn also act on areas responsible for memory and movement, which helps us automatically build up memories for what is good for survival. The problem is that addictive substances hijack our natural reward system. Every substance has slightly different actions on the brain, but one thing all addictive drugs have in common is that they produce a pleasurable surge of dopamine. Addictive drugs all cause dopamine to flood the reward pathway 10 times higher than a natural reward would. Over chronic use, nothing else natural is quite as rewarding. In fact, as substance use increases, the circuits adapt and reduce their sensitivity to dopamine, a phenomenon known as tolerance. For example, let's say a person takes cocaine for the first time. The reward system receives a huge burst of dopamine. But as the person takes more frequently, cocaine will be overstimulating the brain with dopamine. This will cause the brain to adapt to these chronically high levels of dopamine. To compensate and adapt to this new normal, the brain reduces the number of dopamine receptors available in the reward system and releases less dopamine. As a result, that person will feel the need to increase the amount of drug they take so that they can reach the level of high that they're used to. But it's not just the reward system that's affected by this tolerance, since dopamine is also involved in other brain mechanisms. Other brain regions involving decision-making, memory, and judgment also get physically disrupted as a result. The overall effect is to have drug-seeking behavior driven by habit rather than conscious thought, like a reflex instead of a choice. This biological basis helps to explain why addiction really is a brain disease, not a matter of willpower. The stigma that accompanies addiction only makes seeking treatment more difficult.
So again, going through the reward pathway, it's basically dopamine. In this case, is what we're targeting here. So, the body's or the brain's natural response to something good is to release a surge of dopamine into the synapse, and our brains take that up at the postsynaptic cleft there, and we use it, and that's what makes us feel good. It reinforces those pleasurable experiences. In the case of substance use disorders, let's take opioids for example. And we'll see this on a couple slides here, but we have those opioids, they bind to their receptors, they produce an excessive surge of dopamine, which then in turn causes, a huge rush of euphoria, patients feel really good, and then that dopamine slowly gets reuptaken back into the brain, and we start to lose that feeling. The brain then reinforces those activities, so you have this huge surge of dopamine, the brain's happy and everything, so it expects that dopamine to always be there, and then from a receptor physiology standpoint, the brain then will decrease the number of receptors that it has to respond to the dopamine surge because you've got all this dopamine that's hanging out there. Once all of that goes away, well, now the brain is like, well, wait, where did that all go? And so then you start to experience those withdrawal symptoms, those cravings, all of those, and then that's what leads to tolerance and withdrawal and everything. So, key factor here, dopamine. So I know we've talked about this a little bit already, but just to revisit. So this is the neurotransmitter or hormone that's associated with that pleasurable experience. So you have an increase in dopamine that signals that something good is happening and that the brain needs to remember it. So that's where your reward system and that reinforcement come into play. Over time, there are neural changes that allow for these habits to be formed. And so the substance abuse, again, it produces these larger surges of dopamine, reinforces the brain to seek this out, and thus we've kind of fallen into that cycle where essentially the brain is hijacked by that substance, and it continues to want to look for that increased surge in dopamine. And so when we take a look at, from an opioid perspective, we have this image here. You can see on the left side here, looking at the normal brain, we've got our endorphins. In this case, our body's natural analgesic. It will bind to the opioid receptor. We have normal stimulation of dopamine here, thus going into that reward system. But if you look at the other side here, on the brain with opioids, you see you've got a mixture of those endorphins as well as the opioids here. Once the opioid binds to that receptor, you can see you have that excessive stimulation of dopamine there. And so you have this huge surge there, and then over time, again, that's when that brain starts to seek out that reinforced behavior and that habit is formed. Looking at it from the perspective of alcohol use disorder, so how does alcohol affect the body? Specific to the brain here, you have someone who drinks the alcohol, that gets absorbed into the bloodstream, eventually does cross that blood-brain barrier where we see that release of dopamine again. So it all kind of ties right back into that reward system. And of course, alcohol has more effects than just on the brain. We have some short and long-term effects, which we'll see here. So in the short term, alcohol affects our vision, blurred vision, slowed speech, slowed reaction times, impaired memory. I'm sure we've all heard of blacking out from drinking. Short-term effect here. Long-term, though, we have some pretty major side effects. So chronic fatigue, pancreatitis. We're starting to mess with things from a diabetic perspective, regulation of blood sugars, insulin production, irregular pulse and heartbeat issues, and blood pressure as well. Thiamine, or B1 deficiency, is something that is commonly seen here too, which can lead to encephalopathy. So lots of mental confusion, muscle coordination issues, psychosis, all of these things. And then finally, what I think is probably the most prevalent thing that we see is liver disease. And so you've got your fatty liver or cirrhosis, ascites, so all that fluid buildup in the abdominal cavity, hepatic encephalopathy, so the liver's inability to break down a lot of the toxins and things that are harmful to us. So ammonia, for example, is a pretty common one. Leads to a buildup of ammonia in the brain, causes a lot of mental confusion. And then portal hypertension, so now we're messing with the vasculature within the liver, as well as esophageal varices, so risk of bleeding for our patients. So lots of long-term effects to those who are using alcohol on a more regular basis. And then for completeness as well, looking at nicotine, kind of the same story here as well. So you have someone who uses nicotine that gets absorbed into the bloodstream, hits the brain where we see that release of dopamine again. And again, with nicotine use, we have our short-term and our long-term effects. So short-term, obviously, we have some stimulant effects here, some dizziness, headaches, nausea, bad breath, reduced appetite. Long-term, cancer, obviously huge risk of cancer, lung cancer, throat cancer, all kinds of different ones there. Cardiovascular disease, stroke is a big one, diabetes, and COPD, including emphysema and chronic bronchitis. So lots of different things that these opioids and alcohol and nicotine can affect in the body. So I won't dive too much further into the physiology of it. Got quite a few slides to get through, so we'll keep going here. But next we're going to take a look at what some of the preventative and treatment options that we have. So now we'll start to dive into some of the pharmacology. But before we talk about the actual medications themselves, I think it's important to get a brief little overview of the difference between an agonist and an antagonist medication. So looking at this image here, on the left side, we have the before drug column. And so you can see we have our natural substance. It would fit right into that receptor. And then once it binds to that receptor, it produces a normal cellular response. When looking at the middle column for the agonist, we can see the agonist shaped a little bit differently, but the binding site and everything looks exactly the same. So it's still going to bind to that receptor. We see that enhanced cellular response, more activity. Here's where we're getting more of our dopamine, those types of things. So our agonists, they bind to the receptor site and cause the same action as the substance that would normally bind to it. So think of our opioids in this case here. Then from an antagonist standpoint, you can see here, this looks completely different than the receptor site. We'll still bind there, but the antagonist role is to stop the action or effect of another substance. So in this case here, when that antagonistic drug binds to that receptor, the natural substance can't bind there, and thus you stop that activity from producing. And these are going to be important for us when we go through a lot of these different medications here. So for alcohol use disorder, we'll take a look at your disulfirams, your acamprosates, naltrexone, which is a pretty common medication. For opioid use disorder, we have our buprenorphine, our methadones, you see naltrexone again, and naloxone. And I started naloxone here because we're going to spend a little bit more time focused on naloxone because there's some recent changes to that becoming over the counter and things. So we'll review that pretty heavily here. And then for smoking cessation, we have our nicotine replacement. So that's where we come with our gums, our lozenges, our patches, things like that, as well as varenicline or Chantix. And here we see bupropion again, marketed as Zyban. So first off, let's take a look at the medications that are used in alcohol use disorder. Like I said, naltrexone, this would be one of the first ones that we'll cover here, but this one is also used for both alcohol use disorder and opioid use disorder. So it's an opioid antagonist. So here we're blocking that opioid from binding to its receptor. It also blocks receptors that are associated with those rewarding effects of drinking, as well as alcohol cravings. And so when we have the repeated absence of that pleasurable effect of the opioids or the alcohol, it gradually reduces those cravings. Of note here, treatment should begin after the patient has gone through detoxification. It helps avoid any withdrawal effects. Problem with naltrexone, though, is compliance. It is a once daily medication. It's something that I equate to almost like a blood pressure medication. When you take it, you don't necessarily feel better. Of course, you're certainly over time going to reduce those cravings and things for the alcohol or that opioid, but it's not something where you get that instant satisfaction of feeling better. So I feel like compliance with these is not the greatest, but there is Vivitrol, which is a long-acting once monthly injection. So you kind of weigh the pros and cons there. A once monthly injection versus a once daily tablet that you have to take could facilitate some increased compliance there too. So acamprosate, so Dr. Sullivan's favorite mechanism here, not completely known. So it's thought here that acamprosate works to help restore the balance between the excitation and inhibition of neurotransmitter, so it plays some sort of role within that reward pathway. It's used for the maintenance of abstinence from alcohol in patients that are abstinent at treatment initiation. And it can also help reduce some of those withdrawal symptoms, things like insomnia, anxiety, and restlessness. And then we look at disulfiram. So this one blocks the oxidation of alcohol, which is a key step in the metabolism. It increases acetaldehyde, which as that gets into the circulation, that's what we consider like the hangover effect kind of. That's what makes us feel bad after we drink, things like that. So taking disulfiram along with alcohol produces a lot of those same side effects that we can see here. I won't read through all of them, but flushing, head and neck throbbing, nausea, vomiting, palpitations and chest pain, all kinds of stuff. So disulfiram here, while it's used to manage sobriety in chronic alcohol use patients, make sure that's never ever administered to someone who's currently intoxicated or without their knowledge. Another medication that I see a lot that reinforces that disulfiram reaction. I'm sure we've all seen metronidazole used in our pharmacies before. Metronidazole with alcohol will also produce the same disulfiram reaction, so induces just some pretty heavy side effects. So it's a good deterrent if a patient is trying to maintain sobriety from alcohol. So, and then last one here we have Topamax or topiramate, not FDA approved for alcohol use disorder. It is used off-label. Again, exact mechanisms not known, similar to that acamprosate, where it's thought to work on that balance between the excitation and inhibition of those neurotransmitters in the reward pathway. All right, let's shift gears a bit and go through some medications used to treat opioid use disorder. First one we have on the list here is methadone. So methadone here is a long-acting opioid agonist, which might already pose the question, if we're trying to treat opioid use disorder, why are we using an agonist to treat that? Kind of the same goes to the next slide when we talk about buprenorphine, and then we'll go through a little bit more detail, but it just seems kind of odd that you would use an agonist that's supposed to elicit the same effect as the opioid, but you're using it for treatment. But methadone here, so long-acting opioid agonist used to prevent withdrawal symptoms and reduce cravings in patients who are addicted to opioids. It is a Schedule II controlled substance, so something worth remembering there. These patients are also part of a treatment plan. So they're working with their providers, working with a treatment facility. I'm sure we've all heard of methadone clinics, those types of things to obtain these medications. Buprenorphine, it's a synthetic opioid. It acts as a partial agonist at the opioid receptor, so not a full agonist, so we're going to generate a limited effect here. It doesn't cause the same euphoria or sedation that's associated with opioid use, and it can reduce or eliminate withdrawal symptoms associated with opioid dependency. It does have a low risk of overdose if used properly. So we'll talk about Suboxone briefly on the next slide, but that's the combination of the buprenorphine and naloxone. So that's used to help decrease its misuse. Naloxone, if the Suboxone is taken as it's prescribed, as it's supposed to, naloxone has no effect. But if someone were to try to inject the Suboxone for whatever reason, then that naloxone really kicks in and it will take that opioid right off that receptor and elicit a pretty good withdrawal response. So, and then two, for those of us working in outpatient pharmacies who are processing these types of prescriptions, important to note here, as of December of last year, prescribers no longer need to have that XDEA number to prescribe these. So that was a pretty big change in the law. It used to be that you had to have a certain prescriber writing for these medications, and now that has been lifted. So, and then buprenorphine comes in a ton of different formulations. So we have our buccal film, so right in between the cheek and the gum here. We have it for injection, so we have Buprenex and an extended Sublocade here. We've got sublingual tablets, implants, patches, And then our combo products are Suboxone, which is the dissolving film, as well as some sublingual tablets. Typically in the pharmacy that I'm at, the Belbuca, the buccal films, and the Suboxone, those are probably the two that I see most prevalent. I have seen a handful of Butrans used, but primarily I'd say Suboxone is probably the one that I've seen prescribed most often. And then that brings us to our question here. So is using an agonist or a partial agonist like methadone or buprenorphine replacing one addictive substance for another? Short answer to this, no. Both of these are prescribed or administered under monitored or controlled environments. When they're used as directed, and I stress that as directed here, they are safe and effective. And if you think about it too from the perspective of their onsets of action, if you have an opioid, or let's say heroin, for example, that's injected, you hit those opioid receptors really quick. You get that big initial rush of a response followed by that crash. Whereas if you're using the methadone and buprenorphine as prescribed, they're more longer acting. You're going to get more stable levels throughout the brain, and that's just going to help kind of mitigate a lot of those withdrawal effects. Really helps control those cravings and everything too, because we have stable release of dopamine through an extended period of time rather than that big rush up front. And then next we'll talk about naloxone. So we can see here we've got four different types of, we have our injections. We use it with an atomizer. We have an auto injector. And then probably the more commonly used Narcan, which is the nasal spray. So how does naloxone work? And so we can see in the graphic here that receptor on the left side with the pink opioid molecule on it. The opioid is bound there, doing everything that it would normally do, as we've seen before. Naloxone comes in and kicks that opioid right off the receptor. So obviously, knowing that it just kicks that opioid right off the receptor, we have a really good response, and this is used to help treat overdose, just like it says here. So we're treating overdose in this scenario. What are some of the side effects associated with naloxone? Most people don't really associate a whole lot with it, but if you have a patient who is opioid dependent and you use naloxone on them, you're going to immediately reduce or get rid of those opioids off those receptors. You could facilitate some withdrawal symptoms there. So your patients may experience some nausea, vomiting, diarrhea, sweating, heart rate increases, and nervousness, restlessness, those types of things. But big news for naloxone nasal spray is the FDA did approve the first over-the-counter one. And so this is something that we'll see stocked in our pharmacies and everything very soon, available for purchase. Hopefully it's cheap. I don't know pricing off the top of my head, but it would make sense to make it more readily available to make it cost effective. But the question here, how will the approval of this help improve opioid use disorder as a whole? I think when I was doing some research for this presentation, I read a stat that kind of alarmed me a little bit. In the calendar year leading up to October 22, there were over 105,000 fatal opioid deaths in the country. That's far too many. If we had ready access to naloxone, I'm curious to see what that number would look like if we were able to, have better access. So again, easier access to treatment. It's more readily available in more locations. I look at, I live in Omaha, relatively decent sized city. We have access to it, but you go around the surrounding areas outside of our metro area, there's really small towns that don't readily have access to a lot of these types of resources. If this is over the counter, we could see it in our grocery stores, in our local pharmacies, things like that. It's something that I think having access to and having someone who's properly trained in how to use it, it's very, very easy to use. I think it's going to go a long way in helping curb a lot of those overdoses. And then of course I put in here training for pharmacy staff. I think it'll be critically important for everyone to know how to use naloxone. if ever a situation arises. Which brings me to the next point, how does one use it? So, I think the first step in knowing how to use it is knowing when to use it. If you use naloxone on a patient who's not suffering from an opioid overdose, it's not going to do anything. So it's in your best interest to use it. But how do you recognize an opioid overdose? We have some common signs and symptoms here. So we've got the face is pale, they feel clammy, body's limp, fingernails or lips have a kind of that purplish blue color. Pinpoint pupils, so really tiny pupils there. Patients making like a vomiting, or they're vomiting or they're making like gurgling type noises. They're unable to speak, they can't be woken up. Even with a sternal rub, rubbing on the chest right here will wake just about anyone up. If they're not waking up from this, there's a good chance it could be an opioid overdose. Or if they're breathing or heartbeat slows or stops. So good idea to get the Narcan out and give it a try. So how to, here are our steps. So hypothetical situation, we're in a pharmacy, you have a patient in your lobby who appears to have passed out. You recognize signs and symptoms right away. We have naloxone readily available. First thing we want to do, let's grab that, bring it over to the patient. We want to carefully lay them on their back. After that, we want to obviously remove the Narcan from the package, kind of self-explanatory there. But then we want to make sure to hold it properly so that we can effectively use it. So holding it with the thumb on the bottom of the plunger, with the first and middle fingers on either side, so kind of like this. You can see the image on the left side here. You want to insert the tip of one of the nozzle into one nostril, and then use the first and middle fingers there as kind of a guide. And then firmly press on the plunger. That will administer the Narcan dose there. And then obviously we want to remove the Narcan from the patient's nose. Next steps, immediately we're calling 911. We want first responders on the scene as soon as possible. We want to make sure to move the patient into a recovery position as suggested in the image here. So kind of rolling them onto their side, separating their legs a bit with their knee kind of cocked a little bit so that they don't roll onto their stomach. They're not also rolling backwards in case they do vomit or something like that. And then their hand is kind of underneath their head to help support them there. And if they don't respond within those 2 to 3 minutes, you can re-administer the dose. Obviously, we want to make sure we're watching these patients very closely. A tip that I got in pharmacy school, if you have to ever administer naloxone to a patient, take a step back, because if they wake up, they are oftentimes combative. I was told first thing that they're going to do is probably try and swing at you because you've disrupted their high. So take a step back, but you want to make sure to monitor them. And if after those first 2 to 3 minutes they don't wake up, we can go ahead and administer another dose. So on the next slide, I have a video clip. I'm probably not going to show it though. And the reason is it's a clip of a real patient who is actively overdosing and getting naloxone. And it shows after a few minutes them coming back to. It's rather uncomfortable to watch. Admittedly, I've watched it a few times myself. You guys have the slides, so if you want to watch at your own risk, please do. Also, with the microphone and the video not working, I want to make sure to keep moving on. But it is something that's uncomfortable to watch, but I think it highlights something that is important. It's something that I didn't really intend to see, but like when I was researching for this, I just did a simple Google search and was able to find countless clips of patients who are suffering from opioid overdose and getting administered or having naloxone administered to them. I think it was eye-opening to me just how prevalent it is. I did a simple Google search and found tons of hits. Didn't have to do a whole lot of digging, anything like that. And so to me, I think that highlights the prevalence of this. It highlights the need to increase the education on how to use naloxone, get it into the hands of everyone who needs it, and have everyone trained on how to use it.
With that naloxone or the Narcan, one dose per bottle, right? So if you're going to give the second in 2 to 3 minutes, you should have 2 products.
And usually each box of Narcan has 2 in it, so you're able to just grab the other one and go.
So I'm from Washington State, I live north of Seattle. With fentanyl, they're resuscitating babies,
Wow.
which is really sad. And the schools and the police, everybody's learning how to use it.
That's great, they're learning how to use it. It's unfortunate and sad that they have to learn how to use it on such a young population. And I think that kind of highlights too, like looking at the different formulations of naloxone, like things like your atomizers, for example. You can kind of tailor a dose to a patient like that. Whereas the Narcan, it's a fixed dose. You're going to give it to your patient and go from there. But yeah, it's definitely important to recognize that this is something that's affecting us all over the country. And the more access we can get to using this type of medication, the better off everything will be. So I will go ahead and skip over that one. And next we'll just kind of shift gears a little bit and talk briefly about smoking cessation and what types of medications we have as far as nicotine replacement. So we have our typical over-the-counter medications here, so our patches, our lozenges, our gums, and these replace some of the nicotine that's historically obtained through smoking. It supplies nicotine without all the other harmful chemicals within the cigarette smoke. Helps lessen the cravings and withdrawal symptoms. There's lots of guidelines on what doses of patch do you use versus how many pieces of gum do you use a day, those types of things. And a lot of it is patient dependent on how many cigarettes they're using a day, the time that they first start using them in a day. And so these are opportunities for us in the pharmacy to work with those patients individually to make sure that they're on the correct regimen. And then we move on to varenicline, or Chantix, which I'm sure we're probably all familiar with. So Chantix, it has a kind of a unique mechanism of action here, that it's a partial agonist and antagonist. So it stimulates your nicotine receptors, but not enough to get that really big surge of dopamine. And it also blocks the nicotine from activating dopamine, and that's how we reduce those cravings and help support abstinence. With Chantix here, we've got the two boxes here. We've got our starting month box, which is that yellow-green one up top, and then our blue continuing month box here. It is a titration, so your patients will start taking 0.5 milligram once daily. They'll work their way up over the course of the first month up to 1 milligram twice a day, and then maintain that. So with the unique mechanism here, again, it all ties right back to that reward system in the brain. But if we look at that second column there, you see the brain cell when smoking. So we have nicotine, it hits our nicotine receptors. We send that signal down to the presynaptic cleft there. We release a ton of dopamine into the synapse there. And then now we've got that, that pleasurable, good feeling. And that's when we're, over time, the brain's gonna recognize and reinforce that. This next column here, the brain, when not smoking, you can see there's nothing hitting those nicotine receptors. The signal that's sent down to the presynaptic cleft there, it releases just a small amount of dopamine, so we don't get those pleasurable effects from the nicotine, and that's what helps facilitate those withdrawal symptoms and cravings. And so then looking at this far right column here, the brain cell with Chantix, we can see the Chantix here binds to those nicotine receptors, sends a signal down, and we have a release of dopamine, but it's not that huge surge that we get when we have nicotine that binds directly to the receptor. And so what that does is it helps kind of facilitate, or lessens the cravings that we see. It lessens those withdrawal symptoms because there still is some of that dopamine floating around, just not enough. And then looking at bupropion here, or Zyban in this case, this one blocks the reuptake specifically of dopamine and norepinephrine. But as far as smoking cessation, rather unclear as to how it's used. Not to be confused with Wellbutrin here, it's used as the antidepressant, but this is specifically the sustained release formulation of Wellbutrin, so it's the 12 hours, so 150 milligrams every 12 hours there. And like Dr. Sullivan already talked to us about, it does have that delayed onset of action, so we want to make sure, a couple weeks prior to starting, or to our actual target quit date is when we want to start taking this medication. And this I thought was rather interesting, Ozempic. I was getting ready for work a few weeks ago, and my wife had the news on, and I heard them touting Ozempic as the next big medication to treat addiction. My ears kind of perked up, and I was like, well, I know, obviously we know it's used for weight loss and type 2 diabetes and things, but it's like, what is it being used for addiction? And so I did some research on it, and I was actually able to find University of North Carolina, Chapel Hill is actually working in partnership with the National Institutes on Alcohol Abuse and Alcoholism. There's some preclinical evidence that our GLP-1 hormone has some impact on alcohol and nicotine intake. And so they want to take a look at a GLP-1 agonist, so like Ozempic, as therapy for smokers who have alcohol use disorder. Their goal in that is to see if the increased levels there of our GLP-1 hormones can help with those alcohol and nicotine motivation to continue to use it. It's about all I could find on the study itself. It's still in its recruitment phase, so I'd be interested to see, give it some time to get through what happens. Everyone's kind of touting Ozempic as that wonder drug, so to say, right now, and if this proves to have some sort of merit, who knows what doors that would open up in the future for other future therapies and things. So, all right, moving on then. So what are some of the resources that are available? What can we do in the pharmacy as pharmacists, as technicians, to help these patients? So probably the biggest resource we have is the Substance Abuse and Mental Health Services Administration. They have a free, confidential, 24/7, 365 referral service. There's the 800 number there. They also have an online treatment locator, so findtreatment.gov. Super helpful. I did some perusing on that website for a bit. They have a lot of great resources on just understanding addiction in general. What are some of the treatment options available to patients? And then, really important, how do we pay for treatment? It's great that we have all of these things available to us, but how do we pay for it? And I think that could potentially be a factor in a patient not continuing through treatment. So they have a lot of different options and resources there as well. And then some other resources, I just linked them all here. Since you guys have the slides, we can take a peek into some of these into a little bit more detail, but National Institute on Drug Abuse, the National Institute on Alcohol Abuse and Alcoholism, National Institute on Mental Health, Alcoholics Anonymous, Narcotics Anonymous. There's so many different treatment options out there. I would encourage anyone who wants to get more information, knows someone who could use this as a referral, take a peek at a lot of these. There's a lot of really, really great information there. So, and then specific to the pharmacy, what can we do in the pharmacy to help these patients? So, put here prevention, education, and assistance. In the pharmacy, especially technicians, we're on the front lines. In the outpatient setting that I work in, our technicians, they're taking the new prescriptions. They're the ones who are typing them. They're the ones who are actively engaged with the patients right away. So being able to identify some of these patients who maybe are using these medications too quickly. They just got 120 Percocet 2 weeks ago. Why do they need another fill already? And being able to identify some of that misuse is a great opportunity for a technician within the pharmacy. So prevention education, a lot of it comes down to communication. Counseling on medications, which obviously is a pharmacist's job, but using a technician who's talking with the patient can recognize maybe some signs and symptoms, working with the pharmacist there to help identify those patients. And then using some resources, things like the prescription drug monitoring programs. Every state has one, and they're invaluable in helping our patients. Where I can't tell you how many times I've been in a situation at work where I have a technician come to me and say, hey, I don't know about this prescription, it was just filled not too long ago. Can we look at the PDMP? We'll take a look together and make a determination on what we want to do then and there. The pharmacy I'm at too, we actually have some other safeguards in place where opioids in particular, if we see a prescription that is above 90 milligrams of morphine equivalents, our system, we have it set, it will flag that every time. And a pharmacist will need to go in and take a look. So I rely on the technicians to bring that to my attention and say, hey, this is a really high dose, high frequency opioid that this patient is taking. Can you do some more digging around? And so we'll take a look in their charts and everything and make sure that these things are appropriately being used. And then, of course, continuing education. Things like this convention are great in getting information out, and helping not only myself learn, but helping you guys learn and reinforce some things as well. And then finally, assistance. So again, going back to the identification and referral, but here I want to focus more on the communication and helping reduce that negative bias or that stigma that's associated with substance use. There's the whole Words Matter campaign, especially how well you guys can see all of that, but what the Words Matter campaign is just a method of communication that is really patient-focused, it's patient-centered. It tries to take some of the negative connotation off of substance use disorders, off of that patient and help focus on them. So you would say something like a person with a substance use disorder rather than calling them an addict. Rather than calling someone a junkie, it's someone who's in active use. A drunk, someone who misuses alcohol, or a former addict, someone who's in recovery. So I think tailoring how we speak to patients who are suffering from these conditions is really important. Again, it uses that patient-centered language. It helps put them a little bit more at ease, I think. Helps make the conversation a little bit more comfortable. And again, it kind of reinforces something that we talked about earlier, in that it's not the patient that is the problem, it's that the patient has a problem. They have a medical condition that needs to be treated, and we're in a position where we can help with that. And then finally, it helps eliminate those negative associations with like individual blame and things like that. So. And with that, I'll take it to a quick audience participation here. Something that I thought was really interesting in pharmacy school, I had a professor who taught a substance use and recovering from addiction course that I took. And one of the projects that we had in his recovering from addiction course was we had to pick something that we used every day, coffee, social media, your cell phone, whatever, and give it up. We had to quit it and keep a journal of everything that's, anytime I was, for me, for example, I gave up coffee. So, I tried to, stay more hydrated, stay a little more active, but I can still remember, documenting a few times where it's like, man, I could really go for a cup of coffee right now. But it's not in the same vein as like an opioid or alcohol use disorder, but I think it helps reinforce a lot of those same principles. And so I just open it up to the audience here. Think about something that you guys use on a regular basis, and think about what it'd be like if you didn't have that for a week, didn't have that for a month. And if you feel compelled to do so, document it down. Write how you feel about it. Write what it makes you. Do you crave the coffee? Do you crave looking at Facebook or Twitter? Things like that. And I think it might help reinforce a lot of these different topics and things that we discussed. And with that, I will open it up for questions.
Thank you for the great presentation. I hope you get some CME for myself. So, Steve Judy will let me. A lot of regulations are in place now. If I prescribe opioids on a chronic basis, there's a lot of things I have to do for these patients. See them every 3 months. If they're over a morphine equivalent per day. Education, one of them is I should be prescribing Narcan so that they have it on hand. Is the nasal Narcan what commonly I should be working?
That's the most common, what we use. Again, so in my pharmacy, for example, you get a patient who gets prescribed an opioid for the first time. It's required that that physician or that prescriber counsel them on their use. We'll obviously do the same in the pharmacy. Upon second prescription for that same opioid, they're still going to counsel, but there's no true requirement from our organizational standpoint. Third time they get it, Narcan's coming along with it. It will be prescribed along with that opioid. And we typically see the nasal spray. That's the easiest one for us to get. It's the most prevalent. We even have, one of our pharmacies even has a program we'll give it for free. Since we're a nonprofit organization, we're able to do a lot of those things. So you want Narcan and you go to one of our pharmacies, you'll get it for free. Which I think is great because the amount of opioids that we see that come along with a Narcan prescription and the patient that says, no, I don't want the Narcan, that's a lot. There's a lot of patients that don't want it. And it's difficult, for me as a pharmacist, we're counseling on the benefits of using the Narcan if you have to. Sometimes it can get a little bit tough when you're counseling someone on using an opioid and you have to bring up the abuse potential. But it's something it's important. It doesn't take long for someone to get hooked on something like this. So I think it just reiterates the importance of using the naloxone, but it also kind of shows that, at least from my perspective, not a lot of people really want it.
I took a class about it also, and like you said, a lot of people don't want it. But what the speaker told us at a different class about it was if there's any kids that might get into it, or anybody else that might get into it, it might help them, not necessarily the person who's taking the meds.
Yeah.
So it might be something to communicate
Absolutely.
to other people too.
Yeah, definitely. And I still can remember times where I'm counseling a patient on using their oxycodone and spouses in the room, and when I'm counseling on the Narcan, I'm more directed at that person. Obviously the person who's in an overdose situation isn't going to be using it on themselves, and so we're doing everything we can to educate spouses, kids, neighbors, whoever it may be. Trying to get the word out there is really important. So.
Yeah, I just wondered when you talked earlier about like the negative effects of alcohol and you have the long term. Do those effects just vary person to person? Is there a general time frame you can put on when the negative long term things start happening?
I think it's pretty personal, and I think a lot of it depends on things like the fatty liver and the ascites and encephalopathy. Like the fatty liver, obviously, although those things come first in the general progression of the disease, but I think a lot of it has to do with how long has the patient been using for, how much are they using for, and one thing that I think is interesting in some of the cases that I've seen, I can remember back when I was on rotations, I was on a hepatitis service, and we were looking at a patient who had fatty liver disease, and we looked at their blood work and their liver enzymes, their ALT, AST, all that was relatively normal. And we're like, well, what's going on? Well, the disease had progressed so much already that it didn't really have much of the enzyme to give off, or their hepatocytes weren't able to produce enough of it. So it's something that's it definitely progresses over time, but I think it's a little more individual. But I've seen pretty young, 20s, 30s, on up to elderly, so kind of a full spectrum. All right. Well, thank you.